paper number 421 by Professor Bhavana Sharma. Is she here? Bhavana Sharma? Dr. Sucheta Parija? Here? Okay. What's your name? Kanika. Okay. Okay. Co-author. Right. Okay.
Good afternoon, all. I'm going to present the clinical profile of atypical mycotic keratitis in tertiary eye care center, the evolving trends. So the commonly encountered fungal species in routine practices as we see are the Aspergillus fusarium and the Candida. But infection with rare and emerging organisms should be suspected in cases of therapeutic failure or when the infection runs an unusual course. The emerging and rare fungi species includes the Schizophyllum commune, Acrimonium, Curvularia, Cladosporium, Microsporidia, and Fusarium solani. So here we present 6 cases of atypical mycotic keratitis. A 56-year-old female who presented with pain, redness, and watering for 1 month, PLPR inaccurate, with a history of vegetative matter injury, who presented with centrally located dry ulcer 7 into 3.5 mm with endothelial plaque and 3 mm hyperpion. Microbiological investigation showed fungal hyphae on gram stain, whitish fluffy growth on culture, and it was identified as Schizophyllum commune. 2 AC washes were given with intravitreal, intracameral voriconazole and TPK with supportive antifungal medications were given. A 30-year-old female, a 30-year-old male who presented with pain, redness, and watering for 15 days, PLPR accurate with a history of injury with husk, and presented with 8.5 into 8 mm central dry ulcer with corneal thinning. And culture was positive for Schizophyllum commune. Systemic and topical antifungals were given, followed by TPK at later date. In the third case, 57-year-old male who presented with diminution of vision, pain, redness, and watering for 15 days with a history of vegetative matter while working in farm, with a large quadrangular grey-white corneal ulcer with branching edges and dry, rough texture, with deep stromal infiltrates, and new vascularization from 11 to 1 o'clock, and microbiological investigation showed hyaline septate hyphae on KOH mount, and LPCB mount showed numerous oblong and one-cell conidia suggestive of Acrimonium species. Fourth case, 14-year-old male who presented with pain, redness, and watering with a history of blunt trauma to left forehead in RTA, leading to left eye proptosis and exposure keratopathy. And on morphological examination, the ulcer was dry looking, 9 into 7 mm in size, irregular margin, brown pigmentation over the surface, involving the central cornea. On scraping on KOH mount, branched septate hyaline hyphae were seen, and on fungal culture, Curvularia species was seen. Empirical treatment for fungal keratitis was given, and USG guided supraorbital collection aspiration was performed, and after reduction of proptosis, temporary tarsorrhaphy was done to oppose the eyelids. Fifth case, 40-year-old female, pain, redness, watering, PLPR accurate, history of injury with sand particles, 7 into 7 central dry ulcer, overlying plaque and hypopyon of 2.5 mm. And the fungal culture, it showed Fusarium solani. Systemic and topical antifungals were given, and glue BCL was done. Optical PK was done at later date. 30-year-old male with a history of wooden stick with 6 into 5 mm central corneal ulcer with satellite lesions and endothelial plaque with hypopyon 2.5 mm. Fusarium oxysporum was isolated from the culture. Systemic and topical antifungals were effective. So the conclusion is that mean age of patients is 39 plus minus 9 years, belong to rural settings, and there was a history of ocular trauma with vegetative matter. And other attributable risk factors which were noted were diabetes and chronic steroid usage. So the schizophylum cases were refractory to medical treatment, and they progressed to corneal melt and perforation and underwent TPK. Acrimonium species responded well to medical treatment. However, the ulcer progressed and evisceration was done due to non-compliance of the treatment. Curvularia cases were managed medically and underwent optical PK at a later date. In fusarium, they responded well to medical treatment. So my take-home message is atypical fungal keratitis can be difficult to treat owing to misdiagnosis and delay in diagnosis and management. Careful history of the predisposing risk factors, onset and clinical course should be taken. Special microscopic stains and culture media should be used to isolate the organism, and treatment compliance should always be ensured. Thank you.
What all antifungal drops you started for these patients?
Ma'am, 5% netamycin that we started, ma'am, hourly during the daytime and 2 hourly during the night time. And when after 2 weeks, if the response was seen, it is the time duration is increased 2 hourly, then it is given. And
Other than netamycin, did you give any other drops?
amphotericin, ma'am,
So
0.15%.
Yes. Did you make it and
Yes,
also
ma'am, we
start for these cases which are not responding to
not
netamycin?
responding to yes, ma'am.
Yeah. And then how did you decide that? I mean, what was initially we all start netamycin, and then when do you add amphotericin? This is my question.
Okay.
My first question was whether you add. Yes, you said amphotericin, which
Yes,
is
ma'am.
ideal. And then if it is not responding to, have you given AC wash also?
AC wash, yes, ma'am.
With what?
AC wash with amphotericin, ma'am.
No.
I've-
With amphotericin?
Uh,
There is something else also. So the main presenting author is not there, probably.
uh,
Okay. And oral,
intrastroma-
yes. No, so you don't know. So your presenting author should be there when you are showing that you have done ultrasound guided tap. So how was it done? What was the response to that tap? Why was that done? And then you are doing tarsorrhaphy. What was the cornea? Did the patient undergo TPK with such a high orbital pressure? So what have you tapped? What was the need for the orbital tap for a corneal ulcer patient? This is what. Did the patient have endophthalmitis also? Was vitrectomy done? These are all the questions. Any idea?
no, sorry.
Okay, thank you.